Hello and welcome to the Interacoustics webinar on the application of wideband absorbance in clinical evaluation of middle ear disorders. Let me introduce myself. I'm Sree Aithal and I work as a consultant audiologist at the Townsville Hospital. Now, Townsville is located in the coastal town of Queensland, which is also home to the Great Barrier Reef. I've been working in the area of wideband absorbance since about 2009, and I completed my PhD on the identification of middle ear dysfunction in young infants. With the structure of today's presentation, we'll be covering a few things, starting with the principles of wideband reflectance and absorbance, the benefits of wideband absorbance and ambient and pressurized absorbance, as well as the normative variations due to age, gender, and ethnicity. We'll also be covering a few things about the clinical applications, and we'll cover some of the case studies with various middle ear pathologies and how we can improve the diagnostic accuracy, as well as use wideband absorbance for post-operative monitoring. And then we'll summarize the whole webinar towards the end. Wideband acoustic immittance measures refers to a family of measures, and it includes absorbance, reflectance, admittance, phase angle, resonance frequency, various measures. However, in this webinar, we'll be concentrating only on the absorbance measures. So let's start with wideband reflectance. Now, wideband reflectance is also known as power and energy reflectance. Now, when sound energy is given to the ear, some of the energy is reflected back and quite a lot of energy goes into the middle ear. So the wideband reflectance is defined as the ratio of the reflected energy to the incident energy, and the values range from 0 to 1. So if no energy is reflected by the tympanic membrane, then the reflectance is 0. And if all the energy is reflected by the tympanic membrane, the reflectance is 1. So the reflectance can vary anywhere between 0 and 1. Now, some of you may be confused about reflectance and absorbance. Now, reflectance and absorbance are reciprocal measures. Earlier studies have mainly reported in terms of wideband reflectance. In 2013, there was a workshop of experts held, and then they all came to a consensus that we need to start reporting the values in terms of absorbance. So, because as audiologists, we are all quite familiar with the A-type tympanogram and a nice positive peak, so absorbance would be much easier to interpret. So from 2013 onwards, you'll see the articles reporting in terms of absorbance. So as I said, they're reciprocal, and absorbance is 1 minus reflectance. So wideband absorbance. Now, when we say wideband absorbance, it's actually an indication of middle ear efficiency, because it shows how much of energy is absorbed by the middle ear and then transmitted further on. Now, wideband absorbance is the ratio of energy absorbed by the middle ear to the incident energy. So if all the energy is absorbed by the ear, then the absorbance is 1. And if no energy is absorbed, then the absorbance is 0. And you can have any values in between. Some people quote in terms of percentage. So you can either say between 0 and 1 or in terms of percentage. So if there is a 30% of energy being absorbed by the middle ear, then the wideband absorbance will be either 30% or 0.3. What are the advantages of wideband absorbance? Now, compared to tympanometry, which is a middle ear measure, wideband absorbance has quite a few advantages. Now, apart from being fast, objective, and non-invasive, it provides information over a range of frequencies from 250 Hz to 8 kHz. And one of the major advantage is that it can be conducted at both ambient and pressurized condition. Now, with ambient pressure condition, because there's no pressurization of the ear canal, it's less uncomfortable for young children. So you're likely to get very good results because of that. And also it means that we can do the assessment immediately after grommet surgery, so where there's no pressurization involved. And Wideband absorbance is also known to detect conductive pathology with much high accuracy. And it can also distinguish between different kinds of middle pathology rather than being limited to the 3 or 4 basic shapes. And it's less susceptible to than the OA and ABR measurements. So you're quite likely to get much more clearer results with wideband absorbance compared to tympanometry because of these factors as well. Now let's have a look at our typical wideband absorbance trace. So before we begin with the patterns, we'll just look what is depicted here. On the x-axis, we have got frequency in kilohertz, starting from 250 hertz to 8 kilohertz. And on the y-axis, the absorbance is given either in percentage, or in some cases it could be between 0 and 1. The shaded area here, the shaded area here depicts the normative range, which is 5 to 95 percentile, and the dark line that is within the darkened shaded area shows the absorbance of that particular person. Like as in all cases, the left ear is depicted with the blue line, and then the red ear with the right ear with the red. Let's look at typical normal wideband absorbance for an adult. This is an example for a normal adult taken from the left ear of an adult patient under ambient pressure condition. When I say ambient pressure condition, there is no pressurization of the ear canal. As we do the OAs, we keep the probe in the ear and then give the sound and then measure the amount of energy being absorbed. The typical pattern in older children and adults is that the absorbance is low in the low frequencies, and then it increases around up to 1 kilohertz, and then it's highest between 1 to 4 kilohertz, and then again it reduces after 4 kilohertz. Now, absorbance is maximum between 1 and 4 kilohertz, and this is where the middle ear is the most efficient. Various studies have shown this pattern to be the same, where the absorbance is the maximum between 1 and 4 kilohertz. Now, this is the absorbance, and if you have seen the previous articles, you'll see it being inverted, and then you'll see the reflectance being the least in this frequency range. Now, this was the pattern with the ambient pressure condition. Now, we will go on to the pressurized condition. Here, we can measure the absorbance when the ear canal is being pressurized, that is like similar to the tympanometry. We introduce pressure between plus 200 to minus 300 decapascal, and the absorbance is measured across various frequency range. Now, absorbance is presented as a joint function of both the pressure and frequency, and hence it's a three-dimensional graph. From this three-dimensional graph, we can draw various two-dimensional graphs and across various frequencies as well as various pressure points. So you can get a curve at 226 hertz tympanometry, or you can get 1000 hertz temp, or even a temp at the peak tympanometric pressure. Similarly, we can also get the curves of the absorbance at peak tympanometric pressure or at an ambient pressure. So we can even choose the pressure and then the frequency that we want to analyze, and then we can go from there. What are the additional information from wideband tympanometry? Now, wideband tympanometry also provides information across various frequencies, but at various ear canal pressures. So you can analyze at the absorbance at each different pressure point. It also gives the tympanometric curves for all the different probe tone frequencies. Like it gives like almost the tympanometric curves for each of the pressure curves, which means that you can get simultaneously the tympanograms for 226 hertz and 660 hertz as well as 1000 hertz. It also gives additional information such as phase angle information, as well as the resonance frequency of the middle ear, which is quite important in identifying some of the middle ear disorders such as otosclerosis or ossicular chain dysfunction. It also gives a wideband average curve. At the peak tympanometric pressure, we can draw a curve. So on the left-hand curve, you see the wideband absorbance under ambient pressure condition. And in this graph, you can see the ambient curve as well as wideband tympanometric curve, which is derived from the pressurized condition. In most of the normal conditions, they're nearly similar. The wideband absorbance at ambient and pressurized conditions are nearly similar to each other. However, in some cases, the wideband tympanometric curve can be slightly higher than the ambient pressure conditions, especially in the low to mid frequencies. Now we have seen the wideband absorbance under ambient pressure condition and at pressurized condition. Which is better, absorbance at ambient pressure or tympanometric pressure? Earlier studies have shown that wideband tympanometry is better than wideband absorbance. It had better test performance and had higher accuracy compared to the ambient pressure condition. But later studies have shown that wideband tympanometry has similar test performance to absorbance at ambient pressure condition. So there's not a big difference between either ambient or pressurized condition. So do we have to measure only one in that case? Let's have a look at a couple of the slides and then see whether we need to use both the tympanometry, the wideband tympanometry and then the ambient pressure curves. So, before we go on to the various patterns of wideband absorbance, let us look into the probe fit with the measurement. Before we proceed, we need to make sure that the probe fit is really adequate. If it's inadequate, it can compromise the validity of measurement as well as interfere with the calibration of the testing procedure itself. Certain middle pathologies can have very low absorbance. However, if you get a very flat curve very close to the bottom of the graph, it's quite suggestive of a blob probe. So you need to have a look at the probe and then make sure that there's no blockage either with the wax or with any debris there. On the other hand, on the left-hand side, you can see another case of an inadequate probe fit. Here, the probe fit is pretty loose and then that is shown as increased absorbance in the low frequencies, especially between 250 Hz to 800 Hz. There are no definitive criteria to determine the probe look for different age group. However, a recent study has shown that in case of adults, any increase in absorbance of more than 0.2 or 20% in frequencies from 200 to 500 Hz is suggestive of probe leak in adult subjects. Whereas with newborns, up to about 0.7 between 200 to 800 is taken as a sign of leakage. So make sure that the absorbance is pretty much within the normative range and then not quite high, especially in the low frequencies over there. That's a definite sign of probe leakage there. So you need to make sure that the probe fit is adequate before you go on to the testing the patients. Though we say a normative curve, there can be a lot of variations due to age, gender, year, and race on wideband absorbance. It's quite important to understand the normal variations in absorbance due to these factors during the assessment of middle function. An understanding of normal variation will help you to determine whether the particular pattern is a normal variation or is it suggestive of any middle dysfunction. So let's take the factor with the age. So before that, you can see that there's no single pattern to determine a normal wideband absorbance, both in the ambient and pressure condition. Instead, there can be several variations within the normative range. So clinicians need to focus on the overall pattern rather than just the individual frequencies. The frequency range between 1 and 4 kHz is the most important frequency range for middle assessment, whereas the low frequencies are more of the contribution from the ear canal. Frequencies from about 5 kilohertz upwards are not diagnostically significant because there's a lot of variation within the normative pattern, so they do not have a diagnostic significance compared to the mid-frequency range of 1 to 4 kilohertz. And understanding normal variation is very important for the clinical application of the wideband absorbance. Now let's look at the developmental difference that occurs due to age. Developmental changes that occur in the outer and middle ears, they affect the acoustic property of the middle ear, especially during the first 2 years of life. As you can see in the 4 slides, there's a significant developmental change in the absorbance and tympanometric patterns across various age groups between childhood, from birth to adulthood. The largest change occurs in the first 6 months of age, as you can see in the top 2 slides. And then from then on, it slowly changes even up to about 9 to 10 years of age. At birth, the absorbance is high in the low frequencies, almost up to about 50 to 60%, and demonstrates multi-peak patterns. By 6 months of age, the absorbance is reduced in the low frequency range and also in the high frequency range here compared to the newborns. You can see that the frequencies below 1 kilohertz and then above 4 kilohertz have come down in the 7-month age group. While the increased pattern of the large absorbance at 1 to 4 kilohertz is maintained, there will be still developmental differences between infants and young children. Even in adults, a significant difference has been found between young adults and older adults, with the older adults showing reduced absorbance in the high frequencies. So you can see that the normative range also varies according to the age group. So it's important to understand the variations due to age and use the relevant normative normative data for each age group. And you can see that there are 2 consistent patterns here across all ages. One, the absorbance is highest again between 1 and 4 kilohertz, and then the wideband absorbance and tympanometric pattern show similar pattern in all the age groups. Now let's look a little bit closer in at the wideband absorbance in the very young infants. Maturational effects of the conductive system is most evident in the first 6 months of life. During the development of the infant ear, there are several anatomical changes. For example, changes in the shape and increase in the length of and diameter of the external auditory canal, decrease in the cartilaginous portion, and increase in the bony portion of the canal wall, changes in tympanic membrane orientation, increase in the volume of the tympanic cavity. Several of these changes occur, and the effect is very especially observed in the first 6 months of age. Now, these developmental changes influence the acoustic properties of the ear. First, the multi-peak pattern seen at birth usually disappears into a single peak by 4 to 6 months of age. Second, the wideband absorbance reduces with increasing age, especially for the frequencies from 250 Hz to 500 Hz. Wideband absorbance in the low frequencies is highest at birth and lowest at 6 months of age. Third, the absorbance increases in the 2500 to 5000 Hz range from birth to 4 months. Now, given these developmental differences, it's very important to use age-appropriate norms while assessing the middle ear function in neonates. So we need to be careful when we assess the neonates and then see and use the appropriate age norms for these infants. Next, we come to the effect of gender and ear on absorbance. To date, studies have not provided convincing evidence on the effect of gender on wideband absorbance. Few studies have reported small differences between males and females. In young adults, women have been reported to have low absorbance in low to mid frequencies, but higher absorbance at 4000 Hz than men. And even in infants, wideband absorbance has been reported to be low for males at frequencies less than 2000 Hz. However, quite a few studies have not shown gender effects on wideband absorbance. Hence, the gender effect on wideband absorbance is quite inconclusive, and definitely it's not significant clinically. Similarly, the difference between right and left ears is also not conclusive. Some infant studies have shown significant differences between ears, while other studies have not shown any significant difference between the right and the left ears. Let's examine the effect of race on wideband absorbance. There are very few studies on the effect of race on wideband absorbance. The absorbance has been compared between Chinese and Caucasian children and adults. Chinese children and young adults are reported to have lower absorbance at low frequencies and higher absorbance at high frequencies compared to their Caucasian counterparts. Similarly, Chinese children have increased absorbance in the mid-Caucasian counterparts. Let's look at another severe race, wherein Australian indigenous children, they have reported to have a very high rate of otitis media, which starts very early in age and then persists through childhood. Wideband, we did a study where we used a group of tests to determine their middle function, like tympanometry, autoacoustic emission, ABR, and if they pass all the tests, it was considered to have normal middle function. So even when they passed all the tests in both the groups, the Aboriginal infants had lower absorbance compared to the Caucasian children. However, when they failed the test battery, the Aboriginal children had much lower absorbance compared to their Caucasian counterparts. And this was very significant in the mid-frequency range, where the middle ear is the most efficient. So that brings us to the question whether is the difference physiological or pathological. It's possible that the ethnic difference could be related to possible dissimilarities in the anatomical structure and physiological function of the auditory system between the two groups. Wideband absorbance difference has been partly attributed to differences in body size between Caucasians and Chinese individuals. If this is the case, then ethnic specific normative data is needed. However, there's an argument that the lower absorbance seen in indigenous neonates could suggest that these infants have a more significant outer and middle ear condition than the Caucasian infants. So if we take that argument, that means that we do not need to have an ethnic specific data because it's an abnormal middle ear status, not race-related middle ear condition. So the argument, it's quite interesting, but then there's a lot of research that needs to be done comparing their anatomical head and neck anatomical structures. So there's a long way to go before we decide on that. Now that we have known the effect of the age and gender and the ear and the race on middle ear on the wideband absorbance, let's have a look at some of the case studies with various middle ear pathologies. Now, all these examples have been taken from the Titan equipment with the patients attending our clinic. However, the patterns are also consistent with those being reported elsewhere in the literature. Now, to begin with, I need to stress that these are only general patterns associated with the middle ear disorders. At this stage, we don't have objective criteria for determination of each of these middle ear disorders. There are only one or two studies that have developed the objective criteria for a couple of middle ear disorders, but we do not have for as a general criteria. Moreover, the patterns do change with the progression of the disease, and also there's a significant overlap between normal pattern and middle ear pathologies. So it's important to note that wideband absorbance measures, they are not standalone measures. They should be interpreted along with other audiological measures to improve the identification of middle ear pathologies or even differentiate between possible middle ear pathologies. Let's take the most common one, which is otitis media with effusion. The wideband absorbance traces from the right and the left ears are given in the slide. Now, the VRA showed a moderate sloping to a mild conductive loss in the better ear, and in otitis media with effusion, one of the common patterns is that the wideband absorbance is reduced in the low to mid frequencies and a sharp peak seen between 3 and 4 kHz. Now, ambient and pressurized conditions are affected in similar way with otitis media with effusion. Animal and human studies have shown that absorbance generally decreases as the the fluid fills the middle cavity, and more significantly after about 50% of the cavity is filled with fluid. This effect is seen mostly below the 3 kHz region. The absorbance in high frequencies change less as fluid replaces air. Another common pattern seen in ears with otitis media with effusion is that absorbance is reduced uniformly across the whole frequency range without any obvious peaks in any frequency region. Again, both the ambient and pressurized condition are affected similarly. As the fluid fills the middle cavity, the sharp peak in the high frequency is abolished, but absorbance generally reaches a low value at all frequencies. These two wideband absorbance traces are taken from ears of a 6-year-old child with bilateral otitis media with effusion. Each ear demonstrates a different pattern. The absorbance is reduced equally across the entire frequency range in the left ear, while the absorbance is reduced with a peak in the high frequencies in the right ear. The difference in the absorbance pattern can be attributed to the differences in content, amount, and the viscosity of effusion. For the people who evaluate infants and children, we see the middle effusion is very common, and we compare the patterns of effusion between infants and children. And when I say children, with a mean age of about 6 years, the most common pattern with the neonates and young infants was uniformly reduced absorbance across the whole frequency region, whereas in children, the most common pattern was the reduced absorption in low to mid frequencies with a peak around 3 to 4 kHz. Let's look at the next condition, which is a patent grommet. Wideband absorbance can be useful in the determination of the milieu status when in the presence of grommets. The typical pattern found with grommet in situ and is increased absorbance in the mid to high frequencies, especially between 0.5 to 1 kHz with a patent grommet. Another condition that commonly seen in the clinics is tympanic membrane perforation. In ears with tympanic membrane perforation, absorbance can be either normal or increased, mainly in frequencies below 2000 Hz. Location of tympanic membrane perforation does not greatly affect absorbance. However, absorbance varies with the size of the perforation, with the small perforation having the largest effect. Absorbance is shown to increase with tympanic membrane perforation at frequencies below 1000 Hz. It can be pronounced around 1000 Hz for very small perforation, and as the size of the perforation increases, the absorbance peak shifts to higher frequencies. This slide shows a range of wideband absorbance pattern seen in ears with dry perforation. As said earlier, location of perforation does not affect the absorbance much. While there is no generic pattern with various perforation, slightly pronounced absorbance in the low to mid frequencies can be seen as the size varies from pinhole to a total perforation. Most of the studies have been reported on dry perforation. Our limited experience has shown that unlike dry perforation, there's no absorbance pattern that can be specific to the wet perforation. The next one would be a healed perforation. A compliant tympanic membrane, such as an ear with a healed perforation, demonstrates increased absorbance around the 1000 Hz region. However, the absorbance across the mid to the high frequencies will be quite within the normal limits. Nevertheless, you have to be careful in determining this, because even ossicular chain dysfunction can give rise to an increased absorbance pattern around this frequency region. Hence, it's important to couple the wideband absorbance measures with tympanometry to differentiate between an abnormal tympanic membrane and ossicular chain dysfunction. In autosclerosis, step-based fixation is the common the process. So the typical pattern with autosclerosis is reduced absorbance in frequencies below 1000 Hz, with the absorbance usually within the normal range in the mid to the high frequencies. The reduced absorbance in this frequency range is attributed to increase in stiffness due to step-based fixation. However, this pattern may change as the disease progresses, and there's a significant variation due to this. So the early autosclerosis would be much different to an advanced autosclerosis. With ossicular chain discontinuity, the discontinuity can occur anywhere in the ossicular chain. For example, there is the incudostapedial joint or the stapes crura or the neck of the malleus. Ears with ossicular chain discontinuity demonstrate a significant increase in the absorbance in the low frequency region, and especially around the 500 to 1000 Hz region. The sharp peak-like maximum in absorbance is generally well above the normative range, not as slight as compared to the floppy tympanic membrane. The ossicular chain has a definite peak in the low to mid frequencies, below 1000 Hz. In contrast to the ears with autosclerosis, the cholesteatoma pattern shows an reduced absorbance in the high frequency regions. In the earlier stages, the pattern can be normal in the low to mid frequencies, but with a reduction in the high frequencies. An example shown here is that of a 10-year-old child with history of recurrent ear infections. The medical practitioner, the general practitioner, had done otoscopy, but he was unsure of the findings. He described the findings as white material poking through the tympanic membrane. Since he was a 10-year-old boy, the GP thought he might be too young for cholesteatoma, but he wanted to rule it out anyway, so he referred to the ENT clinic. The tympanogram was unremarkable over there, with a mild low-frequency conductive hearing loss. Wideband absorbance showed significantly reduced absorbance in the high-frequency region, so we thought he needed a bit more investigation for his mid-ear condition. So, and then further investigation showed that the cholesteatoma was confirmed with that child. In this slide, it's a much more advanced condition of the cholesteatoma, and you can see through the within the behind the ear tympanic membrane as well, a significant cholesteatoma buildup there. With the advance in the ear disease, the absorbance is now reduced across the whole frequency range, not just in the high frequencies. These are some of the patterns associated with some of the common middle ear disorders. Now that we know the normal variations and some patterns associated with some of the middle ear disorders, let's see how we can apply wideband to improve the diagnostic accuracy during clinical evaluation of middle ear function. First of all, let's take again our first example of otitis media. Wideband absorbance can assist with identification of wideband of otitis media in children. And especially with young children, where it's difficult to administer a battery of tests or do automicroscopy, diagnosis of otitis media and conductive loss can be challenging. In a pilot study, we administered wideband absorbance just before the patients had their ENT surgery, probably just about an hour or two before the ENT surgery, and we compared the results with the myringotomy findings. The outcomes of myringotomy we divided into having effusion or dry ears, which is no effusion. Markers in red denote a significant difference at that particular frequency, and that is to say that, like, if it's in normal versus ears with OME or effusion, if it's marked red, that means the difference was significant at that frequency between these two conditions. As you can see, the absorbance was reduced in both the ears with and without effusion, but the ears with effusion had more reduced absorbance compared to the dry ears. And this difference was significant in the mid-frequency range here, and again the very high frequencies. But as I said, the high frequencies are not as diagnostic important, so it's the mid-frequencies that is of the area of interest. The effect in ears, they're going to be commonly here the serous effusion and then glue ear. Glue ear is a bit more thick effusion, whereas serous is thinner effusion. The effect of fluid viscosity on absorbance, it's not conclusive. There's one study that has said that it doesn't make much difference, but it's not widely studied. The ears with effusion, we classified them as being either serous or thin effusion, or glue ears or thick effusion. There were some differences between each of the condition, mainly around the 800 to 1500 frequency range, and again between 3 and 4000 Hz. Glue ears had the lowest absorbance across the whole frequency range. Absorbance in ears with serous effusion was higher than that of the glue ears, but mainly at 3 to 4000 Hz. Dry ears had increased absorbance between 1250 to 2000 Hz and again at 5 to 8 kHz. Next, we compared the pressurized absorbance in ears with and without effusion. Here again, wideband tympanometry showed reduced absorbance in both the condition with ears with and without effusion. That is, ears that had effusion as well as dry ears. But when we compared the OME or the ears with effusion and dry ears, we could see that the difference was significant across most of the frequency range, except in the low frequencies. And we know that these low frequencies are mainly a contribution of the ear canal. But wherever the middle ear is efficient, so we can see that significant difference is present across the two conditions. Now, interestingly, when wideband tympanometry is compared in ears with and without effusion, there's a large difference that was present between ears with glue and serous effusion across the entire frequency range. The absorbance was significantly lower across all the frequencies in the ears with glue ears compared to that ears with the serous effusion. So we can see that the absorbance was significantly reduced with the ears with glue, whereas compared to the ears with serous effusion. So viscosity did make a difference in terms of the absorbance. However, the most interesting observation in ears with and without effusion is the difference between the two conditions. That is, a difference between the pressurized and the non-pressurized condition. There was a difference between both the condition, that is a pressurized and non-pressurized absorbance in normal ears and then the dry ears, whereas there was no difference between the wideband tympanometry or the ambient pressures in the ears with glue ears. So a comparison between wideband absorbance in pressurized and the non-pressurized condition provides valuable information regarding the presence of effusion, and hence it contributes to improved diagnostic efficacy. Another example is when we compare with tympanometry. Now let's look at this example here. Now, although tympanometry and wideband absorbance are direct tests of milieu function, wideband absorbance is reported to have better diagnostic accuracy at identifying milieu effusion in children. In this example, taken from a 6-year-old child with OME, the 226 Hz tympanogram shows an A-type tympanogram with normal milieu pressure and compliance. However, the wideband absorbance and in both the tympanometric and then the ambient pressure conditions are significantly reduced across the whole frequency range. This child was seen by the ENT specialist and his otitis media with effusion was confirmed. So this example shows that wideband absorbance can be very useful in cross-checking the milieu function. It can add useful diagnostic information about the middle ear, and it can also be used to cross-check the milieu function, especially when the results are ambiguous or not clear. Now, one of the common statements made by audiologists is that C-type tympanograms denote negative milieu pressure and possibly eustachian tube dysfunction. However, C-type tympanograms do not always imply eustachian tube dysfunction. C-type can be seen with or without middle ear effusion. And wideband absorbance can be especially useful in determining ears with and without middle ear effusion. Let's see how it can be used to determine the presence or absence of effusion. Now, in this slide, the patient had C-type tympanogram, and as it can be seen, the mid-ear pressure was minus 377 decapascal. Hearing was reasonably within normal range with some conductive component present in the low frequencies. But when you look at the comparison of the wideband absorbance and the wideband tympanometric curve, you can see there's a large difference between the two conditions. During ambient pressure, which is the line in gray, the absorbance is reduced in frequencies below 2000 Hz and is within normal limits above 2000 Hz. However, under pressurized conditions, at peak mid-ear pressure, the absorbance improves drastically to the normal limits in the low to mid frequencies. So usually in the absence of the effusion, if it's a negative mid-ear condition, the wideband tympanometric curve improves significantly compared to that of the ambient pressure condition. In the next slide, now we look into from an ear with a confirmed otitis media in the right ear. Tympanometry again showed a C-type tympanogram here with minus 364 decapascal. Audiogram showed a mild to moderate conductive hearing loss. And on the graph on the left side, you can see the plotting of both the wideband absorbance at ambient pressure and at peak tympanometric pressure. The absorbance is low across the whole frequency range under the ambient pressure condition. And during pressurized condition, although it improves slightly in the high frequencies range, the absorbance doesn't show much difference in the low to mid frequency range. The absorbance under pressurized condition didn't change significantly with the ears with effusion. Now, there's another related phenomenon here with C-type tympanogram with and without effusion is also the autoacoustic emission. Although not shown in the presentation, Titan can perform both the transient and distortion autoacoustic emission at two different pressures, ambient and peak tympanometric pressure. Often it can be seen that there's no difference in emission between the two pressure conditions in ears with effusion. On the other hand, when there's no effusion, autoacoustic emissions improve and are much stronger under peak tympanometric pressure than under ambient pressure conditions. So both your tympanogram as well as the autoacoustic emission show us improvement when you measure at peak tympanometric pressure than at the ambient pressure condition. In summary, we can say that it's important to measure both the absorbance at ambient and pressurized condition to differentiate between ears with and without otitis media, and also in ears with eustachian tube dysfunction. Ears without effusion show improved absorbance up to about 1050 Hz under pressurized condition. In comparison, ears with effusion do not show any difference with the change of the pressure as compared to the ambient pressure condition. Wideband absorbance is very useful in assessing mid-ear function of ears with perforation. Tympanograms usually reveal a B-type tympanogram with a large cavity volume in ears with tympanic membrane perforation. However, it does not determine the function of the structures behind the perforated eardrum. Now let's look at an example of how wideband absorbance can contribute to improved diagnostic accuracy in ears with tympanic membrane perforation. We had a 12-year-old boy present to our clinic with history of ear discharge. He's had history of previous unsuccessful laryngoplasty in the right ear. He had bilateral subtotal perforation with chronic ear discharge. Tympanometry showed a bilateral B-type tympanogram, and audiology evaluation showed bilateral conductive hearing loss. Wideband absorbance was significantly reduced across the whole frequency range. However, as we've seen with the previous slides, we know that the perforation doesn't show this typical pattern of absorbance. If it is only perforation, then we can see increased absorbance between 1000 and 2000 Hz depending on the size of perforation. However, because this was not typical of only perforation, we referred him for ENT for further investigations and management. Further investigations revealed that this patient had mesotympanic cholesteatoma, incunostapedial joint disarticulation, and dense fibrosis of mid-ear environment along with subtotal perforation. So he underwent subsequent surgery and he had total clearance of cholesteatoma. He also had some reconstructive surgery with cartilage tympanoplasty and partial ossicular chain reconstruction and prosthesis insertion. This case demonstrates the diagnostic value of wideband absorbance in ears with tympanic membrane perforation. In addition to tympanograms that may show a B-type tympanogram, it's very valuable to assess the ears with wideband absorbance as it can give you additional information about the structures behind the eardrum. In addition to improving diagnostic accuracy, wideband absorbance can also be useful in postoperative monitoring and reviewing middle ear function. Now, wideband absorbance can be useful in assessing the middle ear function following grommet surgery. Tympanograms in ears with patent grommets often show flat tympanogram with large cavity volume. However, this does not provide information about the middle ear function. It can show a flat tympanogram without much information about the middle ear condition. Now, in this case, the preoperative assessment showed reduced absorbance with presence of otitis media, and again, postoperative follow-up showed the returning back to the normal middle ear function, with the absorbance being within the normal limits in most of frequency range. However, the increased absorbance here in the low frequencies is very typical pattern seen with the patent grommet. Another surgical procedure that's commonly seen in the ENT clinics is myringoplasty. And wideband absorbance can be used to evaluate postoperative assessment for myringoplasty. There can be various outcomes following myringoplasty depending upon the technique used. Often tympanograms will show a B-type or a AD-type tympanogram. On the left-hand side, the wideband absorbance shows normal middle ear function following myringoplasty, whereas on the right-hand side, it shows pre- and post-operative audiogram as well as absorbance from a patient who underwent myringoplasty and ossiculoplasty. And as can be seen here, he still has a mild conductive loss, and then the middle ear function is much reduced in the mid to high frequency range. We show some more example of tympanoplasty, and in this slide, the post-operative results show improved hearing thresholds. This example compares the pre- and post-operative findings following tympanoplasty, and we can see here that following surgery, the thresholds have improved at low frequencies. And when you look at the tympanogram is still abnormal. Outcome of tympanoplasty surgery can be varied depending upon the nature of surgery and the structures involved. Absorbance can be used to demonstrate the improvement in the middle ear function following tympanoplasty in 3 patients, and you can see the outcomes are quite different in the patients. Another big advantage with wideband absorbance is it can be used to monitor middle ear function following surgery, such as removal of cholesteatoma. This is an example of a 39-year-old patient who underwent mastoidectomy without reconstruction in the left ear. Postoperative audiogram showed a mild loss in the high frequencies, and tympanometry showed a flat tympanogram. On the other hand, wideband absorbance demonstrated normal middle ear function in the low to mid frequencies and slightly reduced absorbance in the high frequencies. Now, wideband, this pattern can be usually used to monitor any recurrence of cholesteatoma. One way to monitor the cholesteatoma is to have either the X-ray or the CT regularly. So instead of exposing them to radiation, this could be a potential tool to monitor the progression of cholesteatoma. This is another example of postoperative review to monitor the middle ear function for cholesteatoma. This slide shows an example of a 15-year-old patient with history of radical mastoidectomy and autoria. The wideband absorbance is significantly reduced in the mid to the high frequency range, and then this can be monitored for further progression of the disease or following his surgery to monitor the postoperative improvement. As shown in this slide, wideband absorbance can be used to review postoperative findings following stapedectomy. The audiogram here shows significant improvement in thresholds up to about 4,000 Hz. Tympanogram shows AD-type tympanogram. On the other hand, wideband absorbance is within normal limits in the mid to the high frequency range with increased absorbance below 1000 Hz. And that was a consequence of the floppy tympanic or the scarred tympanic membrane, but with normal miliar function. This is another example of post-op stapedectomy where the tympanogram shows A-type tympanogram. However, the miliar function is still reduced in the presence of increased tympanic membrane mobility. As shown in the previous slides, wideband absorbance can therefore provide information of the miliar function when the tympanometry results are not very conclusive. So, in summary, wideband absorbance and wideband tympanometry, are not standalone tests and should not be interpreted in isolation. They should be combined along with other audiological measures such as the airborne gap, etc. As we have seen with clinical examples, both the absorbance at ambient and pressurized conditions are useful in identifying miliar pathologies and pre- and post-operative monitoring. They provide very useful information that improve accuracy of identification of miliar pathology as well as monitor the miliar function for progress or any improvement of the miliar disease. It's very important for clinicians to be aware of age-appropriate norms and normal variations. Knowledge of normative pattern will assist in better identification of miliar pathologies. At this stage, we don't have objective criteria for identification of various miliar pathologies. However, we can see literature emerging in this direction. Clinicians need to be perceptive to the effect of various miliar disorders on the wideband absorbance in various frequency regions. So understanding the normal variation helps you in differentiating with the miliar pathologies as well. Pressurized absorbance is an additional tool that can be used to improve diagnostic accuracy. Comparison of ambient and pressurized absorbance has been found to be very useful in differentiating ears with and without effusion. Nevertheless, importance of wideband tympanometry in identifying disorders in other miliar disorders is not examined as extensively. So we'll be seeing more of research coming in this direction to assist in the identification of other miliar disorders. And thank you for listening. We do have a question here. One of the question is, I would like to ask you a question about your experience with PE tubes. Have you seen cases where the PE tube seems to be working well while the absorbance measure shows a miliar problem after all, like findings like glue? We do find that we work quite closely with the ENT clinic, and then we see that if the grommets or the PE tubes are patent, we do get the normal absorbance in the mid to high frequencies with a slight increase in the low frequencies. However, if the grommets are blocked, then we do see, and if the effusion is building up, then we see reduced absorbance across a region. And then they do show quite a clear difference. It's quite interesting to see that wideband tympanometry is really showing a lot of potential in terms of otitis media, and hopefully we can see it in the application of other miliar disorders as well. Yeah, thank you everyone, and thank you to the Interacoustic Academy and everyone who helped to make this possible. Thank you very much.